Thank you. I'm going to be referring to some slides that I think have been distributed already to the media. If you go to the second slide, the purpose of today's briefing is very simply to provide an update on the trends in the COVID-19 epidemiology and the health system indicators, and to provide an update on progress in controlling pandemic. We've got a set of key findings, if you go to the next slide, which I think are important to keep in mind. The first is that key indicators of the pandemic continue to worsen, and although the impact varies widely across regions in the province, most indicators are moving in a worsening direction across the entire province. It's important to look as we get into the modeling as well to understand that we are trying to compare ourselves to countries that hit their second wave earlier than we did after accelerated growth or accelerating case numbers during the early fall. But as these countries have faced higher and higher rates of case growth, they have struggled to control the pandemic, and all the countries we'll be comparing ourselves to today are in lockdown. It's important to note that long-term care home resident mortality is increasing, and as community spread continues, outbreaks will increase, and as outbreaks increase, the risk of mortality in long-term care homes will continue to increase as well. And at a 5% rate of growth, which is probably a reasonable estimate of where we are right now, our case numbers will likely exceed those in several jurisdictions in Europe that are, as I said earlier on, in some form of lockdown. Under any of the scenarios that we look at, ICU occupancy will exceed 150 beds across the province. This threshold of 150 beds is an important threshold because it's that point at which we need to start canceling planned surgeries, and we can no longer deliver the full slate of planned care right now. We're going to start to present some novel analysis today, too, on wastewater tracking that suggests that first might give us a leading indicator, finally, of progress in the pandemic, and suggests that at least some of the restrictions may have made the current surge less than it could have been. If we could go to the next slide, please. This slide shows the total new cases per 100,000 residents per week across public health units. As you can see, the highest rate here shown is 100 and, sorry, just my own problem with my eyesight here. 130, thank you, 0.5 in Peel, down to all other public health units at just over 25. This is an important sort of slide because it shows the growth across all public health units as we're looking at the growth in the pandemic. If you go to the next slide is the new cases with no epidemiological link across public health units. This slide shows a high level of cases with no epidemiological link across some public health units. It's important to keep in mind, though, that the slide is a result of several factors. The first is community spread. As community spread increases, the number of cases where it's hard to identify the source of that case increases. Second, as the level of cases gets to a certain level, it's very hard to track all of those cases. And priorities must be placed on tracking the most important of those critical cases. And finally, there's also some issues of changing systems here. This doesn't mean that case and contact tracing isn't important. It's an important part of pandemic control, but there are some reasons why this number is high. If you go to the next slide, this slide shows COVID-19 testing percent positivity across public health units again. It's important to emphasize the public health units aren't doing the testing, but this does give you, again, a reasonable picture of how performance on the pandemic varies across public health units. And as you can see, in a number of units, we've got case rates rising. We have percent positivity rising as well. And that gives you an idea that the spread of the pandemic is at this point quite significant. Important to note that we've got high rates of positivity in a number of these communities. Even where we have distinct cities within these public health units, often the percent positivity is high in all of those cities. I think it's also important to note here that if you look at, we've called out the statistics here for a number of the individual public health units, but even when we look at those public health units where the overall case rate is lower, in a relative sense, the percent positivity is now up to 1.9%, which more than doubles what we would have seen late in the summer. So significant growth here in the percent positivity. And if you go to the percent of tests processed within 2 days across public health units, you can see, again, significant variation between almost 90% being processed within 2 days down to just 2/3 in another public health unit. So as you can see here, given a relatively consistent volume of testing, case rates are growing substantially. The percent positivity is growing substantially. And we are starting to not have the ability to track all of our cases. In some public health units, that's quite acute, which means that we are in very clearly a second wave of the pandemic. If you go to the next slide, this slide looks at the percent positivity by age group. And this is important. In younger age groups, we see relatively little hospital use. We see relatively low health consequences. And although younger age groups are entirely capable of transmitting the disease, as long as the disease stays in younger age groups, the consequences for health and for the health system are relatively minor. However, you can see here that we've had substantial growth in the percent positivity in older age groups now, in some cases tripling or quadrupling. And this is very sort of challenging and dangerous news for the health system. If this age spillover as we returned it in the past continues, you will see growing hospitalization rates, growing at an even faster rate, and you will see mortality climbing as well. If you turn to the next slide, and that is slide 9, this slide talks to cases in long-term care homes, both among staff and among residents, and mortality among those residents in long-term care homes. I think it's important here to note that when we made our first presentation this fall, early in October, we saw a relatively small rate or level of overall mortality. We've now tripled the mortality that we reported over that in that first briefing that took several weeks to accumulate. It's now 71 deaths in the past 7 days. And as case rates climb, you can expect mortality to climb as well. I should also note that the 10th of August, at least in the long-term care homes tracker, showed the highest number of deaths in long-term care homes since August 1st. Moving on to slide 10. Slide 10 shows what happened in jurisdictions in Europe. In this case, we're looking at France, Netherlands, the United Kingdom, and Germany as COVID case rates grew. You can see on this chart that all of these jurisdictions impose some form of significant restrictions, what's often called sort of a lockdown at some point. But given the strong case growth up until that point, it was very challenging to get control over the total case growth. Basic idea is that the later that one intervenes in the epidemic curve, the harder it is to get the case growth under control. What you can see if you go on to the next slide is where Ontario would sit compared to these jurisdictions. This is a bit of a challenging slide to look at because what we have done is taken the growth in cases in Ontario, and our model sort of kind of predicted us to right where we are today, about 10 cases per every 100,000 people. And then it looks from that point to see what would happen if we grew at 3%, or if we grew similar to those other countries I've just mentioned at this point in terms of total number of cases. What's important to note here is that at a 3% rate of growth, we actually outstrip the French growth before the end of December. France is right now in a lockdown. Although this is talking about an earlier stage of the growth of the disease or the growth of the epidemic or pandemic in France in the second wave, it gives us an idea where we are relatively to these other jurisdictions. When we built these models a few days ago, 3% was a reasonable way of capturing the 7-day or average 7-day growth in total number of cases. 7-day growth is actually probably closer to about 4% right now, so it's climbing up. This suggests that if we do not take any action, you will find yourself, or if there's not efforts to control the pandemic, we will be higher than France by before the end of December. If you go to the next slide, this is projections at a 5% rate of growth. And it's important to kind of emphasize, although this is only a few percentage points difference, this daily growth rate adds up very, very quickly. And so under the 5% growth rate, before the end of December, we were between 6,000 and 7,000 cases a day, compared to the 3% where we would be between about 3,000 and 4,000 cases per day. So it's important to note that even small changes in the rate of growth result in large changes in the number of cases. The 3-day rate of growth a few days ago was about 5%. It's now 6%. And so if the last few days is a reasonable point of extrapolation, it's fair to say that the 5% is a current or maybe even a slightly optimistic scenario. What you'll see in this chart, though, is that by the using the 5% rate of growth, we actually have more cases than France, the US, or the Netherlands at this point. And of course, France, the US, or UK or Germany at this point, and we're getting close to where the Netherlands are. It's always hard to compare countries. There's different population densities. There's different sets of public health interventions. There's different levels of adherence to the public health recommendations. But in this situation, you see a very, very significant growth of the pandemic. If you go to the next slide, which is slide 13, and these slides are available on our website and I think available on the government website as well, you will see that COVID-19 hospitalizations continue to rise. It is about a 61% increase now over the past 3 weeks and about a 167% increase over the past 6 weeks. Now, it is still a relatively low number of hospitalizations compared to the total number of hospital beds in this province, but it's important to keep in mind as well that our hospitals run very close to capacity at all times. And particularly given the access to care deficit that built up in the first wave, this makes it very challenging to actually get caught up and provide people with the care that they need. Going on to the next slide. It's important to emphasize that while cases are growing dramatically and hospitalizations are now growing substantially as well, there are some changes in how COVID is being treated, which are positive and which should create extra capacity within our system. Particularly on this, you can see that the length of stay in this slide, which is slide 14, the length of stay for patients with COVID-19 has declined, particularly for those patients who are receiving ventilation in the intensive care unit, mechanical ventilation in the intensive care unit. And this is important because you see a substantial decrease in the length of time they're staying there, which should create capacity. However, looking at the case growth that is projected and actually is right now kind of currently tracking exactly where we are, the ICU occupancy under any scenario of the modeling will exceed 150 beds before 2 or 3 weeks are out. And you'll actually see in any scenario really before 3 weeks have finished that first threshold reached at which we need to reduce access to care. This is obviously an important threshold. Important to note that before the end of December, though, within about 6 weeks, almost all of our scenarios take us well over 200 ICU beds being occupied. And in the worst case scenarios, we get up close to 450 ICU beds occupied with COVID-19 patients. At this point, there are significant limitations on the health system's ability to react to additional patient needs. There's significant limitations on the access to care and significant challenges in getting people treated when they have health emergencies. If you go to the next slide, this slide shows the effect of the first wave and now the growing effect of the second wave of COVID-19 cases on access to care. If you look at the dark blue shading here, that's or the medium blue shading, that is the level of COVID-19 cases in the province. You can see in the first wave there was a significant limitation of hospital care, significant limitation of emergency department use, significant limitation or a reduction in access to diagnostic imaging. That started to return with a gradual reopening of hospitals back up to what were 2019 levels. But then again, during the second wave, you can see this starting to come down again, which will add to the deficit of care. However, the challenges on care, on outcomes, are not just limited to what happens in ICUs or what happens in long-term care homes. It's clear that the pandemic will have and is having a substantial impact on mental health and mental health care. Overdose deaths have been a serious public health issue for a decade. We had an average of 34 deaths per week due to overdose in the 3.5 months before the pandemic. This increased to 46 deaths per week in the first 3.5 months of the pandemic, so almost a 40% increase. Although this is related to the onset of the pandemic, we should not expect this to necessarily improve immediately with the conclusion of the pandemic. Although the majority of community and mental health and addiction services have tried to remain open, often with changes or modifications, some access to services has been severely limited, particularly access to residential treatment services. There will be, or we should expect to see also long-term consequences in terms of health and access to services because of this delay in treatment. It's going to be important to continue to monitor the impact of the pandemic on mental health and addictions care and on mental health and addictions outcomes. Finally, going on to slide 18, I'd like to present the first of the analyses on wastewater testing. Cases, hospitalizations, ICU admissions, and deaths are all what we would call lagging indicators. It takes a while between infection and any of these items to actually show up because of waiting for onset of symptoms to trigger testing or the receipt of a positive test from a contact that then leads to further testing. Wastewater testing is a way of getting a sense of where the disease is heading. It's perhaps an early barometer. You can see on this slide, which is slide 18, the results for Ottawa. Sampling at the wastewater plants helps us identify when the RNA from the virus starts to spike within the wastewater. You can see that it starts to grow very, very strongly up until about just after the period where the new restrictions are put in place, and then begins to come down, very much in line with what we've seen with the Ottawa case data. This is likely, the initial sort of reduction is likely due to restrictions placed in Ottawa, or first set of restrictions in Ottawa or limitations mid-September, and then the continuation likely related to the restrictions that came in on October 10th. If you look on slide 19, this is the slide for Peel. Again, you can see this rapid growth, and then really a little bit of a plateau before what we expect will be further growth, reflecting the continued growth of cases in Peel, saying that although restrictions may have had a modifying impact on the total rate of growth, they've not been sufficient to control it. Then just concluding again on slide 20, which are the key findings to reiterate. The key indicators of the pandemic continue to worsen across the province. The impact of these indicators and the level of these indicators does vary across public health units, but it continues to worsen across the province overall. Other countries that have allowed substantial case growth have now found it very hard to turn that curve and arrest that case growth. Long-term care home cases are growing among both residents and staff, and resident mortality is growing substantially. The outbreaks continue to account for about 10% of cases, although we know from some recent research now just published in the journal Nature that indoor environments where health protection is difficult, those are places where there's limited ventilation, where there's close contact, where it's difficult to maintain health protection, really do account for the majority of cases. At a 5% rate of growth, which might be considered either somewhere between current and an optimistic scenario, our case numbers will likely exceed several jurisdictions in Europe that are now in lockdown. We're starting to mount the same curve that they did earlier on this fall. ICU occupancy, we expect will exceed the 150-bed threshold under any scenario within 2 weeks, and it will exceed 400 beds under the worst-case scenarios within about 6 weeks. It's important to note that what we see today will likely actually continue along for a while, even with new restrictions, because of the way that infections turn into symptoms, turn into hospitalizations, and turn into or time delay, and then turn into intensive care unit admissions. The wastewater tracking suggests that the restrictions on October 10th might have actually helped delay or moderate some of the growth that we were seeing. But they are not sufficient necessarily in and of themselves in these jurisdictions. I should note that our modeling does not take into account the most recent set of restrictions that were announced in Peel, which we expect will have some impact on the case numbers. Thank you. Dr. Hoyer?
Thank you, Dr. Brown and Dr. Williams. Good afternoon, everybody. Just wanted to give a quick update about outbreaks and a little bit of context around building off of what Dr. Brown said as well. Today, we're reporting 29 new outbreaks. And if you look at the proportionality, it breaks down to about 18 in the vulnerable sector and in the school sector. 6 are in the public-facing sector, including retail and other settings where the public would attend, and 5 in workplaces. We've also recognized a 57% increase in outbreaks over the past week, with 168 and 632 over the past 30 days. We now see outbreaks stretching across 22 of the 34 public health units, and we see a range of outbreaks. Initially, it was in the most vulnerable sector, in the long-term care homes and in schools. We're now seeing it in a variety of different sectors, as I've described before. As Dr. Brown pointed out, it's important to remember that while outbreaks are something that's identifiable, it's 10% of the cases. And it's really a proxy or an example or a view into what the community spread is. And it speaks specifically to the importance of recognizing the importance of, or the transmission within social settings. Those social settings may be within a home setting, and may be within gatherings that people get together in, or it may be a social setting outside of the home location. But it's people bringing the infection into that social setting, and then that may be where the outbreak is identified because somebody brought it in and then shared it, or the transmission occurred with others. And some key things that we've learned from that and from observations from the public health units are people come to work with symptoms. The screening at work may have not been followed or identified the person. The IPAC, or the personal protective equipment, that was not necessarily being used in the most effective way. And then there's gatherings during and after work. So all of those things contribute to the sharing and the transmission. An important key point is to recognize, and Dr. Brown touched on this, but just to elaborate a little bit further, with the increased number of cases, it's, again, associated with an increased number of contacts, and both of those things, the increased number of cases, increased number of contacts, make it very challenging to be able to identify the source, because trying to understand the complexities of case management with many people that you intersect with makes it very difficult to sort backwards and try to figure out where things where the transmission actually occurred, and then also challenging to be able to contact and connect with all of those who might have been in contact in a high-risk situation, which is important to stop the spread. So all of these things are crucial, and they speak to the transmission. Dr. Brown spoke to the healthcare capacity, and the case management and contact tracing speaks to the importance of the public health unit capacity as well. And finally, what we've recognized through a number of the outbreaks have been associated with specific social gatherings. Just some examples, some Halloween parties, weddings, places of worship, other social gatherings that have occurred. And all of those are important because people gather and there's a risk. Then they travel to other places of the province, and then they enter into other settings, and then the spread continues to occur through the outbreaks.